Hi, I'm Elaine Goodman. I'm the medical director of the medical walk-in unit here at MGH. And it's that time of year again, flu season is upon us, so I am here with Erica Shenoy of ID and Infection Control and Paul Biddinger of the ED and the Center for Disaster Medicine to talk about flu testing and treatment. So as a reminder as to why this topic is so important, a few stats about flu. Every year we see about 37 to 42 million cases of flu in the US. About 17 to 20 million of those result in medical visits, and 530 to 647,000 of those end up with hospitalizations. And lastly, and unfortunately, between 36,000 and 61,000 deaths happen every year due to flu. So with these big numbers in mind, I would like you to just chat with me about, in our busy clinical settings, what do we need to keep in mind to help protect ourselves and our patients from influenza?
So first step that we all should remember is vaccinate. So at every opportunity that you have to vaccinate your patients, definitely vaccinate them. But say you're getting a call from a patient who's coming in, or they've already arrived and they're reporting fever and cough and those kinds of things that could be either cold or influenza. The first step, most important step, is you to give them a surgical mask. When they put on the surgical mask, you're containing the droplets, you're protecting all the other patients who may be in the waiting room or around them, and you're protecting staff. Once the patient's put into a room, the patient removes the mask, and then all the staff members who are going in and out are wearing a surgical mask to protect themselves. The other part in all of this, in every interaction with with patients before and after contact with the environment, is hand hygiene, hand hygiene, hand hygiene. Can't stress that enough. It's incredibly important, and we need to keep doing that as we see these patients, and all patients.
Great. So as we have our patients masked, we're using our good hand hygiene. For a patient with influenza-like illness or ILI, so they've got fever, cough, rhinorrhea, who do we need to test?
It's a great question, and you know, obviously it is cold and flu season, meaning we're going to see a lot of upper respiratory viruses that are not influenza. And one of the hardest things to know is whether to test. And I think it's really important for clinicians to know that we should really only be testing when it's clinically relevant, either from an infection control perspective or a treatment perspective, or both. So people with mild illness, especially those that are going to be managed in an outpatient setting, and those who don't have risk factors for severe disease, shouldn't be tested because it really isn't going to influence their care. In the outpatient setting, there's a rapid test that detects both influenza A and influenza B. Sensitivity is between 80 and 85% depending on the strain. And while that's very helpful, it's not sensitive enough to help with inpatient placement for infection control. So if you're in the emergency department or the inpatient setting, we have a PCR test that is a much, much higher sensitivity. Really important to remember not to send both tests because it's wasteful and it delays turnaround time. So if the patient's going to be admitted, the the PCR is the right test. It's the right way to go. It's important to know how to test. The quality of the sampling really matters, and how to do that correctly is shown on our SharePoint site that we have for flu. So really encourage, make sure everybody knows how to do that well. But that's important. We do result both the influenza test with that PCR as well as RSV. And it gets pretty complicated to know between adults and kids and immunocompetent, immunocompromised patients who gets isolated how, more than most people can remember. And so what we encourage people again to go is to the infection control website. If you get a positive RSV, look and see what your patient needs in terms of infection control isolation. Lastly, besides the flu and the RSV, we do have a viral panel that you can send as well. And a little bit like influenza, we really want to encourage people to be cautious in the testing. Make sure that it really matters for the management of that patient. Of course, we defer to the judgment of the individual clinicians, but this is really need to know from a treatment standpoint, not so much nice to know. Same thing though with respect to infection control precautions, that depending on the disease, the precautions are different, so we encourage people to go to the infection control website. What's really important to know, though, is if you're sending the DFA either from an emergency department or an admission standpoint, that takes a couple of days to come back. And so don't wait or don't delay the bed assignment based on the viral panel because you're just not going to get the results in time.
I think second, we don't preemptively isolate for any of those infections on the viral panel, so it can be pending and it's not going to change the bed placement. I think that sometimes trips people up, but again, we've got the cheat sheets there and it says lab confirmed or empiric, so it should lead you in the right direction, and there's a phone number too, so call if there's any questions on that.
Great. So lastly, we know about protecting ourselves from influenza, testing, who do we actually need to treat?
Yeah, so you're going to be treating patients in whom you are concerned about severe disease, or actually they have severe disease, or they're at risk for severe disease. There's a couple antivirals out there, oseltamivir and zanamivir, and we actually have all the details based on age range and the dosing all on the SharePoint website, so we're driving people to that website. I think the other thing that clinicians need to think about is if they've ordered a test, the rapid test, and it's negative, they may have to make a decision to treat empirically because we know that test is not perfect. And so I think we go into some of those considerations on the SharePoint site, thinking about risk factors that might lead you to treat someone in the face of a negative test. And that's a clinical decision that we all kind of have to make.
Yeah, and again, I would say just because someone's being admitted with respiratory symptoms does not mean everyone needs a flu test. But when we plausibly suspect it, of course, for infection control, we want to make sure we send it. So make sure it's in the clinical differential appropriately, and when it is, make sure you order the right test. That's two things. Thank you so much.